Welcome to the deep dive. So, picture this. You're a junior doctor, right?
Man, we've all been there.
Yeah, exactly. It's like 2 a.m. on a Tuesday, and a patient just rolled through the sliding doors of the ED.
Dive into the chaos.
Exactly. So your mission today is to really master the reality of acute myocardial infarction, specifically STEMI. And we're using the latest authoritative, up-to-date internal medicine emergency reference guidelines to do it.
Because, I mean, the textbook cases you memorized in med school, those clean binary presentations where the diagnosis is just, instantly obvious,
Yeah.
they're the exception. The reality of cardiovascular emergencies is just a landscape of diagnostic muddy waters.
Yeah, it really is. And, our goal here is to arm you with the exact clinical nuances you need to save a life when the clock is ticking. We really want to strip away the textbook illusions and, honestly, the outdated medical dogma that can actually harm your patients.
Yeah, if you aren't prepared to navigate the underlying mechanisms of what's happening to that patient, well, you will fall into the traps waiting for you on the ward.
Okay, so let's unpack this, starting right at the foundation. Because before that patient even hit the triage desk, a catastrophic cascade began in their chest.
Right. It's a chronic disease that suddenly becomes an acute emergency.
Yeah, reading through the pathophysiology sections, it's fascinating. You've got this atherosclerotic plaque, right? Just sitting in a coronary artery. It's been there for years.
Doing nothing, really.
Yeah, but then it ruptures or erodes.
Yeah.
That's the inciting event.
And the moment that rupture occurs, it exposes the highly thrombogenic core of the plaque. It's laden with tissue factor and lipid debris.
And that gets exposed directly to the bloodstream.
Exactly. This is where the coagulation cascade just goes into absolute overdrive. Platelets circulating in the blood, they adhere to the exposed collagen, they activate, and they cross-link.
Wow.
Yeah, so within minutes, an acute thrombotic occlusion forms. A physical clot completely barricades the vessel.
So downstream from that physical blockage, the myocardium, the heart muscle itself, is just rapidly starving. I mean, the oxygen supply drops to zero, but the demand stays the same.
Which is a profound mismatch.
Right. And that leads to transmural ischemia, meaning the oxygen starvation spans the entire thickness of the heart muscle wall from the inside out.
Which sets a terrifying biological clock ticking. The myocardial cells, they switch to anaerobic metabolism, producing lactic acid.
But I'm guessing that only works for so long.
Right, exactly.
Yeah.
Without rapid intervention to restore blood flow, the ischemia progresses from a reversible cellular injury to irreversible necrosis.
Infarction.
Yeah, the muscle dies.
So the classic presentation of this cellular death is something they drill into every medical student. It's that diffuse crushing chest pressure, the whole elephant sitting on my chest thing.
The Levine sign, right? Clenching the fist over the sternum.
Yes. And the pain radiates, often to the jaw, the neck, or the arms. Actually, the guidelines mention that if the pain radiates to both arms simultaneously, that carries the highest relative risk that you are actually looking at a true MI.
And I mean, that classic presentation makes triage relatively straightforward, and here is the massive clinical trap for you on your next shift, the atypical presentation.
Let's get into that, because that's terrifying.
It is. Let's look at the data from the National Registry of Myocardial Infarction, too. They analyzed over 430,000 patients with confirmed acute MIs.
Okay.
A staggering 1/3 of those patients had absolutely zero chest pain when they presented to the hospital.
Wait, really? 1/3 of them?
1 in 3, no chest pain.
That is wild. I mean, expecting every STEMI to present with crushing chest pressure is like expecting every fire to start with a massive explosion, right? Sometimes it's just a quiet, smoldering burn that still burns the house down.
That's a great way to put it. And understanding why some patients don't feel it is crucial. The sources note that older adults, women, and patients with diabetes are the most vulnerable here.
Let's focus on the mechanism behind that. Why diabetes, for instance?
Well, in patients with long-standing diabetes, chronic hypoglycemia leads to autonomic neuropathy. The visceral afferent nerve fibers, the ones that normally transmit the sensation of cardiac ischemia, they're physically damaged.
Oh, wow. So the signal just doesn't get through.
Right. So instead of crushing chest pain, the brain just receives these scrambled, vague signals.
Okay, so they might present with sudden, unexplained dyspnea. Because I'm guessing the ischemic heart gets stiff, which raises pulmonary pressures.
Exactly. Or they might show up with profound weakness or sudden nausea, even syncope from a transient arrhythmia.
Or acute delirium, just because the brain isn't getting enough cardiac output. And the sources point out that women in particular face heavily documented delays in getting that crucial first ECG.
Yeah, because their symptoms are so often dismissed as like anxiety or GI distress.
Which is so frustrating.
Yeah.
But if we connect this to the bigger picture, missing these atypical presentations is deadly, isn't it?
Extremely. The registry data showed that patients who presented without chest pain were less than half as likely to be diagnosed correctly upon admission.
Oh, man.
And they suffered significant delays in evidence-based treatments. Their in-hospital mortality rate was more than double compared to those with typical pain.
More than double.
Yeah. So your threshold for ordering an ECG in these vulnerable populations must be practically non-existent. If something feels off, just get the people.
Absolutely. And the moment that suspicion fires in your brain, the clock starts on the objective data. The absolute mandate is that an ECG must be obtained and interpreted within 10 minutes of the patient arriving at the ED.
Yep, 10 minutes.
But here's a sobering fact from the guidelines that really caught my eye. A single initial ECG misses over 50% of acute MIs.
Because, well, an ECG is just a snapshot of an evolving dynamic process. It's not a static conclusion. A thrombus might be partially occluding the vessel, or the full transmural injury simply hasn't developed enough electrical change to register on the surface yet.
So what do you do?
If your clinical suspicion is high, but that first tracing is non-diagnostic, you must repeat that ECG every 15 to 30 minutes.
Okay, so we all know to look for the classic ST segment elevation. But as a junior doctor, you cannot afford to miss STEMI equivalents.
Right. These are specific patterns that don't meet the strict millimeter criteria for standard ST elevation, but they indicate an acute, complete occlusion of a major vessel.
Let's take a journey around the anatomy of the heart to explain these. Starting with the front wall, supplied by the left anterior descending artery, the widowmaker.
Well, an incredibly dangerous occlusion of the LAD might not show ST elevation right away. Instead, you might see the De Winter sign.
Okay, what does that look like?
This presents as upsloping ST segment depression that leads directly into tall, prominent, symmetric T waves in the precordial leads V2 through V6.
The electrophysiology behind the De Winter sign is fascinating. Before the ischemia becomes fully transmural, severe subendocardial ischemia depletes the cells of ATP.
Right.
And that ATP depletion alters the function of the ATP-sensitive potassium channels on the cell membrane, which drastically changes the repolarization phase.
And that altered repolarization is exactly what physically manifests as those massive peaked T waves.
Got it. Now let's move anatomically to the back of the heart, the posterior wall STEMI. Because standard ECG leads sit entirely on the anterior and lateral chest wall, right?
Yeah, there are no standard leads looking directly at the posterior myocardium.
So it's pure vector physics. An electrical current of injury moving toward the back of the heart looks like a mirror image to the lead sitting on the front.
Exactly. Instead of ST elevation, you see horizontal ST depression in leads V1 through V4.
Often accompanied by unusually tall R waves, right? Because they're the mirror image of Q waves.
Precisely. And if you see that mirror pattern, you have to immediately ask the nurse to place posterior leads V7, V8, and V9 under the patient's left scapula to confirm the actual ST elevation.
Okay, then we have to consider what happens when the heart's entire electrical wiring is abnormal at baseline, specifically like a left bundle branch block, or LBBB.
Yeah, the septum normally depolarizes from left to right. In an LBBB, that pathway is broken, so it depolarizes right to left.
Which fundamentally distorts the ST segments. Because the main depolarization vector is flipped, the repolarization phase, the ST segment, is naturally forced in the opposite direction.
Right, it's called appropriate discordance.
And this can completely mask the underlying ischemic current of injury. You're looking for a signal, but the background static is deafening.
That's where the Scarbosa criteria come in. They look for places where the ST segment moves in the same direction as the QRS complex concordance.
Because that's super abnormal for a bundle branch block.
Exactly. It's so abnormal that it strongly suggests acute ischemia.
Okay, finally, we must look at the right side of the heart. If you spot a classic inferior STEMI ST elevation in leads 2, 3, and AVF, you cannot stop your investigation there.
No, you can't. The right coronary artery often supplies both the inferior wall of the left ventricle and the right ventricle itself. About 1/3 of inferior stemas involve the right ventricle.
So you have to immediately order right-sided precordial leads, specifically V4R through V6R, to catch it. But let me push back for a second here.
Sure.
We just went through all these intricate squiggly lines. Staring at an ECG while a patient is actively crashing is terrifying. What if the machine's automated readout confidently says, normal ECG, but the patient is diaphoretic, clutching their chest, and just looks terrible.
Well, this is where you must trust your clinical acumen over a machine's algorithm. The algorithm is comparing voltages to a database. You are looking at a dying patient.
Right.
Early in an infarction, a patient with baseline T-wave inversions might experience acute ischemia that causes those inverted waves to flip upright.
Oh, pseudonormalization.
Exactly. To the computer, the ECG suddenly looks normal, but it is actually acutely pathological. You must treat the patient, not just the paper.
I love that. Treat the patient, not the paper.
Yeah.
Now, here's where it gets really interesting. Let's talk about that immediate treatment, the actions you take the moment that STEMI is confirmed.
Yeah.
For decades, every medical student has had the mnemonic amona permanently burned into their brain for acute chest pain, right? Morphine, oxygen, nitroglycerin, and aspirin.
Oh.
But reading the latest UpToDate guidelines, it turns out that half of Monona might actually kill the patient.
Yeah. What's fascinating here is how rigorous evidence-based medicine forces us to dismantle long-held dogma. Let's start with oxygen.
Okay. Routine supplemental oxygen used to be an absolute reflex for anyone with chest pain. I mean, more oxygen is better for a starving heart, right?
That's what we all thought. But the DITO-2X AMI trial completely shattered that assumption.
Tell me about that.
They looked at over 6,600 patients with suspected MI. The trial definitively proved that if a patient's oxygen saturation is 94% or higher, giving them supplemental oxygen provides absolutely no mortality benefit.
None.
None. And mechanistically, giving unnecessary oxygen to a normoxic patient actually causes massive harm.
Wait, how?
Because hyperoxia triggers a surge of reactive oxygen species, and that drastically reduces the availability of nitric oxide, which, as you know, is a potent natural vasodilator.
Wow. So by giving oxygen they don't need, you cause direct vasoconstriction of the coronary arteries.
Exactly.
You are literally clamping down the very blood vessels you were desperately trying to open with your other therapies. You're actively working against the goal of reperfusion.
It's totally counterproductive. Next up for dismantling is morphine. We used to administer it freely to reduce the patient's pain and blunt their sympathetic drive, hoping to lower the heart's workload.
Makes sense in theory.
Sure, but massive data sets from the Crusade registry showed that morphine use in acute coronary syndromes is actually associated with a higher adjusted risk of death.
The pathophysiology behind that is mind-blowing. The impression trial proved that morphine physically paralyzes the gut. It drastically slows gastric emptying.
And why does that matter for a heart attack?
Because your life-saving oral P2Y12 inhibitors, drugs like ticagrelor or clopidogrel, they need to reach the small intestine to be absorbed.
Precisely. If you give morphine, those crucial antiplatelet drugs just sit pooling in the stomach.
Oh, man.
You're delaying their absorption and attenuating their peak plasma concentration. While the pills sit in the stomach, platelets just continue to aggregate on the ruptured plaque in the coronary artery.
That is terrifying.
Yeah, you should only use morphine for truly intractable, unbearable pain when all other options have failed.
Okay, then we have nitroglycerin. It dilates vessels, reduces preload, eases the heart's workload, it makes the patient feel better. But the guidelines are clear. Across massive clinical trials, nitroglycerin has shown zero mortality benefit in STEMI.
Zero. It is purely for symptomatic relief, and it comes with massive, life-threatening caveats.
Right. Remember earlier when we discussed checking for right ventricular ischemia with right-sided ECG leads?
Yes, V4R through V6R.
This is exactly why it matters. If a patient has an RV infarct, their right ventricle is ischemic, stunned, and very weak. It cannot pump effectively.
It relies entirely on venous return, the sheer physical pressure of fluid, the preload to push blood through the lungs and into the left side of the heart.
And nitroglycerin is a potent vasodilator, right? It completely tanks preload.
Exactly.
If you give nitro to an RV infarct patient, you remove the only mechanism keeping their circulation going. Their blood pressure will absolutely fall through the floor into severe cardiogenic shock.
It's a disaster. You also have to aggressively screen every patient for recent use of PDE5 inhibitors, like sildenafil, because combining those with nitroglycerin causes catastrophic, irreversible vasodilation.
Okay, which brings us to the A in MONA, aspirin, the unsung hero that actually survives the dismantling.
Yeah, 162 to 325 milligrams, non-enteric coated, chewed and swallowed immediately by the patient.
Because chewing it allows for a rapid buccal absorption. It immediately inhibits the cyclooxygenase 1 enzyme, profoundly halting the production of thromboxane A2.
Which stops the platelets from aggregating at the site of the plaque rupture. So, while we tear down oxygen and morphine, aspirin remains the bedrock of early survival.
It's good to know something still works.
Yeah, and the revised immediate medical management heavily prioritizes potent antiplatelets and anticoagulation like unfractionated heparin or enoxaparin to prevent the thrombus from propagating.
But we must remember that medical therapy is merely holding the line. The ultimate definitive treatment for a STEMI is physical reperfusion. You have to open the blocked vessel.
Time is muscle. The gold standard is percutaneous coronary intervention, or PCI. A cardiologist threads a catheter up the arterial tree, crosses the clot with a wire, balloons the artery open, and places a stent.
And the goal is a door-to-balloon time of under 90 minutes.
Mhm.
Let's talk about logistics. What if you're a junior doctor in a rural, non-PCI-capable hospital, and the transport time to a major center is delayed by distance or like a blizzard?
Well, you cannot let the patient's heart die while waiting for a helicopter. You must adapt. This is where the pharmacoinvasive strategy is critical.
How does that work?
If the anticipated delay from first medical contact to getting a balloon inflated is going to exceed 120 minutes, the guidelines dictate that you administer fibrinolytics, clot-busting drugs like tenecteplase right there in your rural ED.
Okay. You push the lytic therapy, you monitor the ECG closely to see if the ST elevation resolves by at least 50%, which indicates successful pharmacological reperfusion, and then you initiate transfer to the PCI center anyway.
Exactly. You bridge the geographical gap with pharmacology.
And while you are managing these logistics, you can't just stare at the monitors. The myocardium is dying, and the architecture of the heart is beginning to fail.
Right. You have to proactively hunt for the early complications of a massive heart attack. Hemodynamically, you are watching for cardiogenic shock. As the pump fails, blood pressure drops, which further decreases coronary perfusion.
Creating a deadly downward spiral. The patient becomes cool, clammy, and altered.
Yeah. And mechanically, you need to keep your stethoscope glued to the patient's chest. If you suddenly hear a loud, new, harsh, holosystolic murmur, you have a catastrophe on your hands.
Because the ischemic tissue can physically tear, right? Like the posteromedial papillary muscle, which holds the mitral valve closed.
That specific muscle is incredibly vulnerable. Unlike the anterolateral papillary muscle, which has a dual blood supply, the posteromedial muscle relies entirely on a single vessel, usually the right coronary artery.
So if that vessel occludes, the muscle necroses and snaps.
Right. The mitral valve essentially blows open, causing acute, massive mitral regurgitation, flashing fluid back into the lungs.
Or the ischemia can cause a rupture of the ventricular septum itself, creating a traumatic hole between the left and right sides of the heart. These are mechanical failures that pharmacology cannot fix. They require an immediate cardiothoracic surgeon.
And electrically, the starving tissue is highly irritable. Ventricular tachycardia, VT, and ventricular fibrillation, VF, are incredibly common in the first few hours.
So you must have the defibrillator pads attached to the patient, ready to run ACLS algorithms the second the rhythm deteriorates.
Absolutely. But crucially, the guidelines explicitly state we no longer use prophylactic antiarrhythmics like lidocaine drips to try and prevent these arrhythmias.
Right, because suppressing the heart's electrical system broadly can actually have proarrhythmic effects and depress cardiac output further, increasing mortality.
The most effective antiarrhythmic in a STEMI is restoring oxygenated blood flow to the starving tissue.
Reperfusion is the ultimate cure for the electrical, mechanical, and hemodynamic chaos.
Ex-
So what does this all mean for you as you prepare for your next shift? It means you're armed. You know to trust your clinical suspicion over a single automated ECG readout.
You know the mechanisms of atypical presentations. So your threshold to get an ECG on an elderly diabetic patient is incredibly low.
You understand the vector physics of posterior and right ventricular infarcts? You were ready to throw out the dangerous, outdated parts of the M&A mnemonic.
Holding the oxygen if they are normoxic to prevent vasoconstriction, and holding the morphine to ensure your antiplatelets are actually absorbed.
And above all, to relentlessly pursue rapid reperfusion.
You're ready?
But before we wrap up this deep dive, we want to leave you with a final provocative thought. Just something for you to mull over. We've put together 3 high-yield Viva, or exam questions, based on everything we just dismantled.
Oh, I love these. Okay, here's question 1. Based on the DTODOS 2 XAMI trial, why might applying supplemental oxygen to a normoxic patient actually worsen myocardial ischemia?
Think about those reactive oxygen species. Okay, question 2. A patient presents with horizontal ST depression in leads V1 through V4 and tall R waves. What specific leads must you immediately ask the nurse to place?
Hint, it's all about mirror images. And finally, question 3. Mechanistically, why is morphine no longer universally recommended for STEMI pain, particularly regarding the patient's antiplatelet regimen?
Keep those in the back of your mind as you walk into the ward, because understanding the deep mechanisms of what is happening in the body today is the only way you'll be ready to save a life tomorrow. It's what transforms a confusing, chaotic Tuesday night into a clear path forward. You got this, Dis.